Good afternoon, everyone. Technology will come in. Okay. First off, just a few announcements. With the EALs, I went through earlier this week. I was looking at the reports. The majority of you are moving along pretty good at those, and you're at a good pace. I did see that a couple of you have not accessed the EALs at all. You really, really need to get on that as soon as possible. They do take a long time. You can ask some of your fellow classmates. It is better to get started on those sooner rather than later. Even though it takes a long time, it's kind of an easy 100. You're just going through the flashcards. So, and those are worth 20% of your final grade. So make sure that you're logging in and getting those done. If you have been doing those like on your phone, that's perfectly fine. It's just at some point you'll need to get onto like a computer or a laptop and access each one of those chapters. Just all you have to do is just click on them, and it'll take your grade immediately from the Elsevier site and put it into your Canvas grade book. So just at some point, make sure you're going onto like an actual computer or laptop. You can do it here at the LRC if you need to. If the only thing you have is your phone, but computer or laptop, then that'll transfer those grades over. Your discussion boards, still remember, if you do it early in the week, go back at some point later in the week and just reply to 2 other people. I've been seeing some people getting 75s on their discussion boards because they're not replying to 2 people. And those replies don't have to be like this big long paragraph. It can be, hey, Courtney or Veronica, Liz or whatever, hey, great points, on your post, I really like this, or, hey, maybe think about, this or something like that. Just a quick little comment so that I know that you've at least read at least 2 other people's posts, so that you're kind of getting a different perspective sometimes of how to go about like doing some of the things we do in the operating room, and kind of giving you, more than that one way to skin a cat kind of thing. If you're missing any assignments, whether it be, workbook assignments or discussion board stuff and everything like that, if we're still within, I guess today, if you're missing anything from last week, tonight at midnight is your last opportunity to turn that in for a maximum of 75%. So make sure if you have something missing from last week, get it turned in tonight, because tonight's the last night, and then after that, I can't accept it as late work. So your midterm, I've been looking at your midterm and kind of going through it and stuff. I changed the date. It is, you aren't going to do it next Monday, which would be the 19th. It's going to come the Monday after that, the 26th of April is when your midterm is, when you will take your midterm, that Monday afternoon. We'll do it just like we've been doing the quizzes here on Canvas. And if you're having any kind of issues with Canvas, like submitting assignments, or it won't let you do it or something like that, or you're trying to click on a link and it's not working properly or anything like that, shoot me a text in the group text, because you might not be the only one having that problem. And also try to get a hold of Sharita Wagner. She's here on campus. She is our online champion. She's the person that if you're having these issues with Canvas and things like that, you get in contact with her, and then she can she can help you further with whatever issues you're having. She may have a quick fix for you. She may need you to kind of show her what's going on in the LRC, just kind of logging in and show her what's happening. And then she can kind of work you through the fix that way. But let me know so then I can, tag her, and then we can, get those issues fixed for you. Things like that. But that is all the announcements I have. Does anybody have any questions, comments, concerns? Funny stories? We'll save the funny story another time. All right, so let's jump right into it. Chapter 18. Right, this is all about, moving. That's not chapter 18. Stop it. Okay. All about moving, handling and positioning our patient. A lot of this we've already kind of gone over in lab. You guys have been checked off on like moving your patients and some of the positioning and things like that. This is where we'll get a little bit more in depth on some of the concepts. Right. Right. We can move, patients, to and from, either their bed or their gurney to an OR table or to a fracture table or, to a wheelchair, to up to a walker, all those kind of things. We can, moving these patients. So all kinds of different conveyances, they say. It's just like the vehicle once you put them in gurney, bed, wheelchair, whatever. But this is going to create that there's a risk now for both the patient and the healthcare worker. Right? So we have to know how to like lift properly and proper body mechanics and the things that we based on the patient. What kind of surgery did they have, or are they gonna have? Do they have any fractures or things that we need to be aware of? Is the patient kind of diminished in their own strength? How much are they going to be able to help us or not? Those kind of things all have to be taken into account so that we can prepare for the risk of a potential injury somewhere, and we can do certain techniques and things like that to minimize those injuries and things like that, so that our healthcare staff isn't now out of work because of like a back injury or something like that from just moving patients. Patient identification. We talked about this when we were picking up the patients in the lab, right? We're checking that ID band. We ask the patient to state their name and typically their date of birth. Right, that's where we need that two we need those two identifiers, right, that are unique to that specific patient. What would you do? Would you think? Okay. If your patient was deaf, right? How do you go about asking these questions and getting this verification? Right? You might need an interpreter. What if the patient has Alzheimer's and they don't remember their name or date of birth? Right? What if the patient, you don't speak the same language? Right? They're Spanish speaking only, and you're English speaking. These kind of things, we work through, right? If the patient is deaf or they speak another language, we're going to get an interpreter. And we can have like a physical interpreter standing there, or we can use a phone. And the way that the phone interpreter works is that it looks like a regular phone, but you're going to have two handsets. One is for the patient, and the other one is for the nurse or doctor that's verifying this patient and talking to this patient. The nurse will ask a question into the headset to the interpreter, and then the interpreter, they switch over lines, and now they're talking to the patient, will ask them in their native language, and then the patient will reply to the interpreter in their native language, and then the interpreter tells the nurse in their language what the patient said, and that's how that goes. It's kind of a roundabout way kind of thing, and those interpreters have to be like vetted or verified by the hospital that they actually do speak that other language, and that they can speak that other language in a way that they can use like the medical terms and things like that in that language, so that the patient can get the full understanding of everything that's going on. With the Alzheimer's patient, you're probably going to involve a family member at that point. Most often, their power of attorney. And then and we already covered the language. I don't know why it keeps doing that. But yeah, but it's like for those Alzheimer's, you're using a family member. Um, so this like safe transport and transfer, most of your injuries are going to happen because you didn't have enough help, right? Instead of having the 4 people you needed to move, you only had 2. There was no plan. There was no communication about, hey, we're going to move on 3, or we're going to tilt this patient up. Now, remember yesterday, for those when we were doing the lateral positioning. Now, remember just before we started the lateral position, I kind of explained on how it was going to go, what we were going to do. Right? That's that plan. If you just everybody gets up to the patient, and then anesthesia says, "Okay, move them." Where? Right? If you've never done it before, or done it infrequently, right? You're not 100% sure of what you're supposed to be doing. That's why we communicate, talk to each other. People were in a hurry, right? We're trying to get that turnover. Go, 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 go. That speed does not come from moving around real fast. Speed comes from knowing what you're doing and being comfortable in what you're doing. Then you because of that familiarity and that comfortability, now you can move a little faster because you know the steps of things. I usually equate it to like cooking, right? When you first started to learn how to cook, when you were maybe a kid or an adult, whenever, right? You start kind of simple things, right? Macaroni and cheese and oatmeal and stuff like that. And then as you moved along and were learning cooking, you got into more complex dishes. Maybe you started to learn how to make sauces and things like this or whatever, a little more complex. But now when you make macaroni and cheese, it's almost like you're not thinking, right? You like boil water, put the macaroni in, drain the water, add milk, add butter, add the cheese powder, stir it. Oh. But the first time you did it, you were like, okay, and you're like reading the box. All right, put this much water in the pan, boil it. And now add and it took longer because you had to go step by step. Once you know it, you just do. So that's where your speed comes, and your speed of setting up and all that kind of stuff is going to come from doing it multiple times and getting that comfortability with doing it. Another way is that if the patient is disoriented or combative, right? They have that Alzheimer's, or they're not fully understanding of everything that's going on. Right? It could be even a pediatric patient who doesn't want to be taken away from their parents, and now they're you're trying to carry them and take them to the room, or trying to have them in the gurney, and they just want to climb out and go back to mom and dad. Right? So a lot of ways that both the patient and the healthcare worker can get injured, and this is why we learn these steps and what we're doing so that we can minimize this stuff. Some other things to take into account is that a change in posture can cause hypotension. Now, what I mean by that is, has anyone ever been like, you're laying down on the couch or you're laying down in bed or something like that, and somebody in another room, they're like, they get hurt or something like that, and they scream for you, and you jump up real fast and you're headed that way. But because you were laying down and then stood up real fast, you feel kind of like lightheaded and you're like, ooh, and you need to kind of catch yourself. That's your blood pressure dropping real fast. Because when you were laying down, you didn't need to be pushing and pumping your blood with that kind of pressure. You were laying down and relaxing. Now suddenly you've stood up and you've shifted all of that blood. It was kind of just laying like this, and now it needs to get back online. It needs to catch up a little bit. The pressures need to catch up, and you're feeling a little lightheaded because it's kind of drained out of your head. And then your heart needs to be able to push and get it back up into the brain, and the brain get that oxygen back. But that can happen to these patients when we're moving and transporting them and stuff like that. That's why Ortiz had brought up about why we need to put both legs in the stirrups at the same time. Not only are we trying to protect that nerve, but it's also for changes in blood pressure. You can have a drop in blood pressure if you're doing it that one at a time and kind of mess the patient up. Kind of your principles behind transporting your patients, right, is know your risks. The patient could fall out of the bed, so we put the side rails up. The patient could be cold, so we give them a warm blanket. The patient could rest their arm on the side rail and have their hand kind of sticking over. Make sure you keep your hands inside the rails so that you don't catch them on doors or walls and things like that, right? We want to try and protect their personal dignity. That means keeping them covered, not exposing them to everybody in the hospital as we wheel them down the hall. Not with some patients, not as easy to do because they want to just keep taking stuff off. What it means by perform deliberate movement is that you have that plan. You know what you're supposed to be doing, and when you move, you're like, okay, boom, there. I'm going to this spot, so that's where I'm going to go. It's not a tentative like, because the other person who's on the other side, they're going to be moving deliberately, and if you're tentative, they're going to kind of pull away. You may pull the patient away from them, and now nobody's on the same page anymore, and that could lead to injuries of the patient. Right? Know the equipment you're working with. Know how to operate your bed. Know how to operate your gurney, your wheelchair, the walker, whatever it is that you're helping to get this patient moving around with and things like that. Know how it operates. Know how it operates almost to a point where you can troubleshoot when things go wrong. Don't ever abandon your patient. Don't ever just leave them sitting in a hallway somewhere while you go to maybe get their chart or something like that. Take them with you. Right? If there's something you've got to pick up from like the nurse's station or something like that, wheel the patient with you, or go and get that stuff before you even pick that patient up. That way, once you pick that patient up, you're taking them straight to pre-op or straight to the operating room, wherever. You're not having to go back and forth for things. Protecting that patient, that's, reminding them to keep their hands in, right? Making sure that their feet aren't dangling off the end, keep them warm and stuff like that. Make sure you're identifying that patient with that 2 identifiers. Right? You do not want to bring the wrong patient into the room. Because even if we catch it before we move them over to the OR bed and all that, kind of looks a little bad on us. The patient's like, oh, and then that's the story they tell when they go home. Whether or not their surgery was a complete success and they feel great and they had no other issues and all that, they're like, oh yeah, they tried to wheel me into the room. They thought I was somebody else. And that's all they focus on, right? Because that's, as human beings, when we tell stories of things that have happened to us and stuff like that, a lot of our stories are like kind of the negative side. You hear somebody talk about a place, you're like, oh yeah, I've been there. They're horrible. And it's not just the medical field, anywhere. Like, oh, you went to that Walmart? Yeah, they're horrible there, aren't they? Yeah, they're like, oh. Um, and then you want to talk to this patient, tell them, what to expect, who you are, right? Identify yourself. I'm so and so. I'm from the operating room. I'm here to wheel you down to pre-op, or hey, I'll be, one of the members of your team today. I'm here to wheel you into the operating room. That kind of thing. Let them know what's going on. You never want to just walk in there all quiet and be like, "What's your name? What's your date of birth?" Good. You ready? Let's go. Because they're like, I don't know who you are. I don't know where you're taking me. I don't know. I don't know, and that becomes a big source of fear for patients, is that unknown. Uh, Talking with their family, understand that not only the patient, but their family is going to be a little anxious and nervous too. Right? Their loved one is going in to have surgery done, and they're not 100% certain that they're going to see them again or see them alive again. Right? There's always that fear of the unknown. You want to allow the patient to come with, or the family member uh, to walk with you as long as they can. Like if you're taking the patient down to pre-op, the patient's family can be in pre-op with them, so they'll go the whole way with you. But if you're taking that patient to the operating room, well, obviously that patient can't go into the OR department. So then you would let them come with you as far as you can until you have to, take that turn to go into the OR department. And then at that time, you're letting the family know, where the waiting room is, and letting them know that the doctor will be out to speak with them when the procedure's over, and things like that. You're always trying to, reassure the family that patient's going to get the best care possible. We're going to take great care of them, but remember, you're not updating them, or I'm promising them anything. You're not saying, oh, yeah, they're going to make it through, no problem. Don't even worry about it, because that's the time that something happens, and it could be no fault of anyone's. There could be just a spontaneous. They have a cardiac arrest under anesthesia that we didn't see coming. The patient didn't see coming. Their family didn't see coming. It just happened. There was no clues as to, that this was going to be something that could have even been a possibility. And now we got to kind of face the patient's family after we've promised them something. So, and then typically the OR department's going to, and the nurse in the room will take care of kind of this last one. But that's giving those updates, those periodic kind of updates as to how it's going. Like usually the surgeon in the conversation with the patient and their family in their office will explain to them, the procedure, about how long it's going to take and that kind of thing. But sometimes, the procedures take a little longer. And you can imagine as a family member, you were told that the procedure is going to take 2 hours. Well, when do you start counting that 2 hours as the patient's family? It's the minute you walk into the waiting room. But we haven't actually started that surgery yet, right? We haven't cut that patient because we need to get him into the room, administer the anesthesia, get him to sleep, put him in the position, prep him, drape him, and now we can actually start the surgery. So it may take us a good, half an hour or so after getting that patient in the room to getting him to sleep, to getting him to position and all of that stuff before we actually start. So an hour and a half later, the patient's family is expecting us to be done. And now they're out there wondering what's taking so long. Why are they still in the room? Why hasn't the doctor come out to talk to us yet? I bet you something's wrong. That's where we start to lead just as regular human beings, right? We start to kind of envision the worst. And now our fear and anxiety starts to build. everything. And then finally the doctor comes out and your anxiety and everything is at a super high level until the doctor tells you that everything went great. And they're in recovery now and everything's good. Because we've all seen those medical shows that the family's sitting in the waiting room and the doctor comes in and then has to tell them that something happened and that your family member is gone or something like that. And that's what those family, when they see that doctor coming in, because they're coming in later than they said they were going to, that's what's going through their mind. He's about to tell me that they're dead. Body mechanics, right, on how to lift and move things and everything. Make sure, number one, you always have enough help. Never try to move a patient on your own. Make sure you've got somebody helping you, right? Know your limits, right? If you can only lift 50 pounds, you probably shouldn't be over on helping lift the side of a bariatric patient. You should probably be on the feet somewhere, right? Because you don't want to injure yourself either. Right? Be prepared for weight shifts of the patient. Some of you, when we moved Ortiz, maybe got to experience this a little bit, right? When you're rolling them up on their side, all that weight's going to kind of lean towards you. So be ready for that. You know, kind of be bracing yourself to be able to support all the patient's body weight. And keep in mind that with these patients who are asleep and intubated and things like that, they're not helping at all. So you have to support the majority of their body weight. So you just got to be ready to brace yourself and to be able to accept that extra weight and you holding it. We want to maintain that spine in a nice alignment, neutral position. Right? You don't want to twist your own spine when we're talking about maintaining that spine. So you're staying straight. Right? And also, whenever we're moving the patient, we're maintaining their spine in that nice straight manner. You never want to twist or anything like that, especially when you're like lifting something or bending down. You don't want to twist to the side and then bend down because you're putting too much strain on those lower back muscles. And you're going to need them for all the standing you're going to be doing. You want to position yourself as close to that patient as possible, right? That's going to reduce that load or the weight of everything. You bring it in close to you, and now you can use those abdominal muscles and everything to help hold your upper body and make sure your feet are like shoulder width apart, give you a nice wide base, right, for your legs. And then you're just kind of, and then when you go to lift, make sure that your knees are bent before you lift so you can stand and straighten and use the strength and the power in your legs to help bring that patient up. But then also remember that those abdominal muscles are supporting your upper body. And the legs are what gives you that power to actually lift something. When you're doing like a lateral move, so that's from gurney to OR bed, you're going from side to side, right? You can bend your knees like slightly. You don't need to lock your knees because that's not going to be very stable, but you don't need to do like a kind of a deeper bend, right? So that's because you're just sliding, you're just pushing that patient across, right? You're going to roll them up to one side, put the board underneath, and then just push across. So you don't really need a whole lot of bend. You're not doing lifting of the patient. You're not lifting that whole patient off of the bed. But when you're moving vertically, so this is foot to head or head to foot, moving the patient up in the bed or down in the bed, this is where you do need to have that knee bend and have that wide base, and then you just kind of slide the patient. You got to lift them because you never want to slide them across anything. You can cause those injuries, that shearing injury and things. But you just lift like a couple inches off of whatever mattress or bed and then slide up. It's those awkward positions of like twisting or having to like where your feet don't get to be shoulder width apart. You don't have a whole lot of room. Your feet have to be real close together. These are those positions that's going to cause injury because you don't have that support down low in the base. Does everyone know where your center of gravity is? For females, it's down right at about your pelvic and your hip area. That's your center of gravity. For males, it's our chest. This is where our center of gravity is. So you never want to reach too far away from your center of gravity and try and pick something up and hold it up, because now you're using just the muscles of your arms and your back. Your legs are not helping you at all. So you need to bring it. That's why we bring the patient, or we get as close to the patient as possible, so that we're not using those muscles to hold something out away from us. We bring it in nice and close. Transfer devices, right? Gurney, wheelchair, a gait device or a gait belt is like a big leather kind of strap belt that goes around a patient who's like walking on the floor. That's what gait means, is your walk. So that's a patient who needs to be up and kind of walking around. These tend to be like your total joint patients, some of your more elderly patients, so they don't develop pneumonia, stuff like that. But that belt is there, so the healthcare worker is walking right next to them, and they hang on to that belt in the back, just in case that patient starts to kind of weaken or go down. They've got something to hold on to, and then help lower them to the ground. Those lateral transfer devices, the air assisted, that was that air mattress I was talking to some of you about in lab, where you lay that underneath the patient and then you blow it up with the air, and now you can just use 2 fingers and push the patient across because they float on the little air mattress. It's really, really nice. I mean, you can have patients who are like 700 pounds down to patients who are less than a pound, but it makes it really easy for moving the bigger patients and things like that. The transfer board, that was that hard plastic one that had all the little handles on the side, and you would slide over. You guys all got to use the roller board. The patient sling. This is something, if you're moving the patient from like their bed or gurney and you want to put them in a chair or a wheelchair, there's an actual sling. It almost looks like a small hammock that you would slide underneath the patient, and then it's got loops of the fabric, and you hook them onto little hooks. There's an actual machine that when you hook them onto those hooks, it's all hydraulic and will lift that patient off the bed and hold them in that little sling. And then you can move the arm of that over above the chair or wheelchair you want to put them in, and then slowly lower them down into it, and then take the sling off of the hooks, and then now they're moved over. So those are typically, you won't see those in the OR. We're going to use like the air mattress and the roller boards and things like that to move our patients. The sling you'll see most often on the floor, the floor is what they call it, up in the patient's rooms and things like that. And we're hardly ever going to do this in the operating room because either these patients were asleep with general anesthesia, so we've got to transfer them back over to their bed or gurney, or they had even if they had like local anesthesia or something like that, we're still putting them on a bed or a gurney because they have to go into recovery. They got to recover before they can either go to the floor or get discharged to home. And it's much more comfortable for a patient to be lying in a bed or a gurney waiting, waking up from surgery and things like that than sitting in a wheelchair. Especially, they're still going to be groggy and sleepy and stuff like that. And you can imagine somebody in a wheelchair, like their head all back and looking super uncomfortable, being groggy and stuff. So, but we do kind of teach you guys because you may need to help somebody on the floor or something like that. You maybe have just walked on the floor to pick up a patient for the OR, and a nurse pops out of a room and says, "Hey, can you come give me a hand?" Sure. And you go in, and she just needs some help moving that patient from the bed to the wheelchair. Um, Now, the patient, if they're lying down in the bed, you're going to have them sit up first, and then kind of swing their legs to hanging off the side of the bed, and then just sit there for about a minute, because that kind of equalizes that blood pressure, right? So they're not just popping up real fast, and then now as soon as you get them up standing, they get dizzy on you, and now you've got to try to either catch them or get them back on the bed or something like that. So they sit there for just a little bit, for about a minute, and then you slowly stand them up. And then because what you'll do is you bring the wheelchair in right next to the bed, and the side that their feet are hanging off of, the wheelchair is right there next to them. So then when they move to standing, now they just have to pivot and then sit down, because the wheelchair is already right there. You have the locks already set on it before they sit in it, before you even sit them up. You prepare the wheelchair, you bring it next to the side of the bed. If you can, you would remove one of the arms. So a lot of the wheelchairs have the removable side piece, so that you can really get it up next to the bed, and then the bed gives you that piece that prevents them from falling off to that side. So, but then once you sit them down in the wheelchair, you replace the armrest, put their feet up on the little rests for their feet, and then you can unlock it and wheel them wherever you need to go. Or if they just happen to be the doctor order for them to be like sitting up in a chair for certain hours of the day or something like that, to get them up out of bed, then you would just leave them in the wheelchair with it locked. You may even put there's typically not like a strap that you put on a patient in a wheelchair. But then you would, once they're in the wheelchair, then they're good to go. If you're in there by yourself moving that patient, then you would let the nurse who's in charge of them know that they're up in the wheelchair now. And now these are all the steps. So you would sit them up, right? You're making sure that it's the right patient. You want to move towards that patient's strong side. So if they've had like a stroke or something like that, and like their right side is like their weak side, you can kind of see their face drooping, things like that. You would want the wheelchair on the left side of the bed, so that they can use their left arm to hold on to the other armrest for stability. And then you just nice and easy, slow movements. Right? You're not in a real hurry or anything like that. It's just, you go nice and easy, boom, sit down, we're good. Now, if we have to move a patient from a wheelchair to the OR table, again, I've never seen this happen. Everyone who's coming in is either being carried in by the nurse, if you're a pediatric patient, or they're on a bed, gurney. What we would do for the OR table is we're going to lower it to its lowest setting. Then we're going to, bring the wheelchair right up next to the bed, assist the patient in standing up, and then turn them so their back is now to the OR table, and then just assist them in sitting down on the OR table, and then help bring their feet up as they lay their head down. And then that's it. That's that easing into position. And the rotating, so you stood them up out of the wheelchair, and then you just rotated them so their back is now to the OR table, and then easing them into sitting, and then helping them with their legs up to laying down on the OR table. And then you can take the wheelchair, or after you put the safety strap on the patient, then you can take the wheelchair away. The place where you may see this most often happening is if you're working at like a surgery center, and those patients are having like same-day surgeries or something like that, with like local anesthesia. They're not going to spend a lot of time in recovery. So they can do the wheelchairs. So assisting with a falling patient. What do you do if you're walking with a patient and they start to fall? Well, first you've got to position yourself, right? You're going to help ease that patient to the floor. And in that easement, you're going with them down to the floor and you're following that movement, right? You're calling for help because a patient has fallen. They may not have hurt themselves, but they have fallen, right? So you're going to need some help with getting this patient up off the floor. And then you stay with the patient until your help gets there. You never leave them alone. If a patient does start to fall on you, you're not to like try and catch them and keep them up, because you're going to end up hurting both of you in that situation. That patient's going down, you need to go down with them and make it to where they kind of land on you. But that's that piece of that easing them to the floor. So first, this is you positioning yourself. You're going to put a foot between both of their feet. And that's going to allow you to put like your knee or your upper thigh up against their behind, up against their backside. And then you're also going to be positioned behind them, right? If you're walking with this patient, you were right next to them and you had one hand on that gait belt already. So it's not like they just started falling and now you've got to reach out and get them. You already had a hand on them. You just have to slide yourself into position and put your foot in between theirs and get that knee or leg behind their butt and lower back. And this is what's going to help you in guiding them to the floor. So you see how and now they're leaned back on you and you're just going to slowly slide to the floor with them. With your leg ends up kind of behind their back. That's going to keep their head and upper body from going all the way down to the floor. You guys kind of see that? We can demonstrate this in lab too. I'll show you guys. I'll take like a volunteer or something like that and then show you them falling and how you help bring them to the floor. And I'll try to pick probably somebody who's bigger than me so that you guys can see that even the smallest can accomplish this. It's just all about accepting that patient's weight and help easing it down to the floor. Some emergency situations that can arise during transportation of a patient, they become some of the causes is the patient could be hypotensive, they have low blood pressure, which means they're going to be kind of dizzy and not fully cognitively with it in their brain and stuff. They could have a heart attack on you while you're transporting them. They could go into a seizure, right? The seizures, basically, like if you're you're in the elevator and they start seizing up on you, you just want to make sure that you get their head turned to the side. Right? You may need to kind of reach in and make sure that their tongue isn't swallowed back. That's why you kind of turn the head to the side to get that tongue to move forward so they don't swallow their own tongue. But basically, you're just going to try and you can cup the pillow kind of around their head, but you do not try to hold them down. You do not try to keep them from shaking. You're going to cause more injury that way. You just let the seizure happen. You're just trying to protect head and airway. You want to try and maintain verbal contact. Have them keep talking to you because that means they're awake. You want them awake. If any of these things are happening, you want them conscious because if they go unconscious on you, things are worsening. You're going to shout for help. Hey, I need help here now. Somebody, anybody, come, come. If you're in the elevator, you're going to hit that alarm button, and someone in security will contact you through that speaker and be like, "Can I help you?" And then you tell them what's going on. I'm so and so from the operating room. I have a patient here in the elevator, and it looks like they're or they've just become unresponsive. They've gone unconscious on me, and I can't bring them back. I'm in elevator such and such, and then inside the elevator will be like what elevator number or letter or whatever, which one you're in, and then they can come and respond to you and get help to that spot. The reasoning that some of this happens is hypotension and cardiac arrest and seizures and stuff is that sometimes when we move these patients, we're going to cause fluid shifts within like the vascular system, right? It's that whole putting those legs up in lithotomy, right? We're changing blood pressures and things like that, and that can affect the patient's own body systems and what can happen to them. So it's just things we have to be on the lookout for and know when to. For the seizures, it was asked if we should time them. If it's something that you think about in the moment, absolutely, because the more information that you can give to those doctors and the people who are coming to help, the better. If it's not something you think of at the time, it's not really that big of a deal because your main focus is to get help to you so we can help this patient. And then as the help comes, then we can start to work out, the who's and the whys and get more to the bottom of it after we've helped that patient. Lateral transfers, right? We're going from the bed to a gurney, right? We can be going from a hospital bed to a gurney or to the OR table or whatever, right? But this is going in to pick up that patient, right? You go and let like the unit clerk or whatever nurse is taking care of that patient, that you're there to pick up that patient. The nurses on the floor don't like it when their patients just disappear without them knowing, because they go, they have a plan of how their day is going too, and then they walk in there and that patient's missing, and they don't know if that patient got up and left themselves or if somebody came and got them. So now they've got to waste time figuring out what happened to that patient. Like I said, knock, right? Introduce yourself, verify the patient's ID, wash your hands, right? Have the patient see you washing their hands. You may need to arrange the furniture a little bit, move some chairs, and take the patient will have their own little Mayo stand. Maybe over them that's got all their phone and their food and all their little knickknacks and stuff all over it. You got to get that out of the way because you may need to be taking that bed, or they're going to be moving off of that bed. So that needs to be out of the way and give them their room. And then you also need to clear your path to get out of the room. You don't want to start rolling that bed and then, and now you got to stop and go around the bed and move a trash can out of the way or open the door or move the curtain and stuff like that. You make sure that all of that is clear before you start rolling. Or even before you start bringing in a gurney for them to move over to. Right? You're going to lower your rails so they can move over. Make sure your wheels are locked on both the bed and the gurney. And then if they have like a Foley or a colostomy bag or an IV already in, things like that, you're grabbing all that stuff and making sure you're hanging on the appropriate, pole or, off the side of the bed or something like that, that it's nice and freed up, that it's not get tugged on when they try to move over. And then you're going to help kind of guide that patient, right? You have the two people, one person on, the side of the gurney and the other person on the side of the bed. I'm sorry, hang on just 1 second. Yes, sir. He thinks he's so funny sometimes. That was Miss Ortiz. But then you're just helping guide that patient over here. You just need to move over here. And then when they move and they think, oh, okay, am I there? No, a few more inches. Keep coming, that kind of thing. Right. Now, if we need to use that transfer device, that's the roller, the slider, whatever it is, right? We've done this in lab, right? You're lowering your rails, lining up your beds, right? Making sure your wheels are locked on both what they're on now and what they're going to. Making sure all those drains and tubings and things are all up. If there's any equipment, like if they're on like a pump of some kind, like a pain pump or something like that, we need to also bring that equipment with us because the tubings of the IV and stuff are going to be incorporated in that equipment. You know, if they've got a wound vac sponge on, there's a whole like vacuum device that has to go with them. So that has to get put onto the bed with them and stuff like that. If you're using a draw sheet, you kind of roll it a little bit and you're using both hands to grasp and lift or pull. And then we always do it on the count of 3. So it's 1, 2, 3, move. So it's not 1, 2, move. It's 1, 2, 3, move. And after surgery, we bring the gurney back in, right? We have all that stuff lowered. Whatever lines or drains or catheters, tubings, whatever's coming off of them, we make sure, you know, that's up on the patient. We're locking our wheels on both the gurney and the OR table. The OR table should already be locked, but we're double checking, making sure that it is, right? We take the safety strap off, make sure all those lines are up on the patient, and then however we're doing it, if we're using the roller board or, you know, if the patient just had local anesthesia and they're still awake, they might be able to move themselves over, you know, whatever it is. That's, you know, and then we bring that patient over back to the gurney, wheel them over to PACU. If the patient is an ICU patient, then you have that special ICU bed. That patient will not go to recovery room after surgery. They go straight to the ICU. Typically, patients who are still intubated after surgery will go to ICU because they need to remain intubated. Maybe we did some lung surgery or the anesthesiologist didn't really like the way the patient was responding during the surgery and things like that. They're not waking up real well, and they're thinking, we need to keep this patient intubated for a little while longer than sitting in recovery. So we're going to go ahead and send them to the ICU just to be safe. Pediatric patients, never leave a child alone, right? Too many potential for injury. They could fall off the bed. They could get into something that, you know, that's going to hurt them, you know, things like that. The parent will come to the patient to the holding area with the kid. You know, talk to the child. Right? Don't come in and just pay attention to the parents and tell them everything and then be like, okay, come on, and then grab the kid and take off because they're not going to fully understand what's going on. But you talk to the child and let them know, hey, I'm so-and-so, how are you? And just kind of make it, you know, nice and fun and kids are introduced and stuff like that. You know, if you see that they have like a stuffed animal of some kind, you're like, oh, I see you got SpongeBob. I like SpongeBob too. You know, just something to kind of ease them and make them feel a little more at ease, a little better about the situation. You're not going to completely, you know, take away all their fears or anything like that, but you can kind of help make them just a little bit more comfortable. If the child, you know, is really freaking out and you know, like you go to look at their ID band and they're like, no, like they don't want you to touch them or anything like that, bring the parents in. And then, oh, it's okay, you know, and grab their ID band so that you can see it. You don't ever have to touch them, but just so that you can see it and things like that. You're just trying to keep that patient nice and calm. Right? And if they start to really get upset and everything like that, mom can pick the patient up and hold them, or dad can pick them up if dad wants to, or whatever, and just to kind of calm them down a little bit. but also remember that they're not small adults. So you can't use like the big words and do you know what you're having done today? Oh, you're having a cholecystectomy, or you're having your gallbladder taken out. They may not understand what you're talking about. Your tummy hurts. Yeah, you're gonna have surgery to help fix that. Okay, and then you get the clarification from the parents because the child may not know fully what you know understand everything that's going on. Right? Now, there's that no false assurances. Right? You're not promising. You're not, oh, I guarantee, he'll do just fine. No problem whatsoever. We're gonna take the best care we can, or they're gonna get the best care. We're gonna take real good care of them, and then consider, what developmental stage are they in? Are they an infant? Are they a school age child? Are they an adolescent? Or, where are we at with this so that we know how to kind of converse and how I can come and kind of talk to you and treat you in a way. The hearing impaired, right? They should be allowed to keep their hearing aid all the way up to the point that they're going to sleep. Just before the administration of anesthesia is when we usually take hearing aids and glasses from patients. That way they're aware of everything that's going on. Right? If you have a patient who is absolutely deaf and they don't have any kind of like hearing aids or like cochlear implants or anything like that, they should have their interpreter with them the whole time. And if it means that interpreter getting changed into scrubs and putting on hat and mask and shoe covers and everything and coming into the room with the patient, typically we want a hospital interpreter for that, somebody who's employed by the hospital, be there for that patient for that. That way we don't have the family member in the operating room and potential of things going, because you don't know what you're supposed to be doing in the operating room if you've never been in there. You don't know what you can and can't touch and that kind of stuff. And then the nurse is going to have to walk that person back out and get them undressed out of their stuff and all that kind of stuff. So typically we'll use a hospital interpreter that can do the American Sign Language and things like that with these patients. But if we, it's like the weekend, or we don't have that interpreter and the patient's family's not there, then we try to use a lot of hand gestures. I don't want to speak for everyone who's deaf, but they know that the people who can hear are kind of jerks about it. Like, you don't know what you have until it's gone, kind of thing. So deaf people tend to kind of adapt, and they'll pick up, even if you're not using the exact right, signals as far as the official sign language. You can do things like, pat at something and say, come over here to right here. And sometimes they can read your lips. You can kind of pull your mask down a little bit. I need you to move over to this bed. And okay, things like that. If they're just hard of hearing, not deaf, you may have to kind of speak a little bit louder. You're not going to yell you're not going, hey, you need to move over here, right? You just, excuse me, sir, can you go ahead and move on over to this bed for me? Right? Keeping it. What the? Stop it. Okay. But then speak a little slower so they have that time to kind of read your lips if they need to. And that comes with that articulating your words. Don't mumble. Because if they're hard of hearing and now you're mumbling, that they're not catching anything you're saying. And then always look right at the patient. Make sure you're facing them. You're not, hey, can you go ahead and move over to this gurney for me? I'm sorry, what do you need over there? Because they didn't hear you at all. And they don't know that you're speaking to them. The sight impaired, we're going to use a lot more touch with this. This is where therapeutic touch can come into play really well. Uh, you'll even you have the patient use their own touch. You can kind of grab their hand and let them feel the table next to them, and then tell them, I'm going to have you move to your right. You feel that table that's next to you, and then you maybe even get them to feel the other edge that they're going towards. Hey, you feel that edge there? Don't go past that edge, even though somebody is standing there. Right? And then you can kind of reach out and lightly touch, their hand or their arm or something like that to let them know that you're there. And then you're telling them, I'm right here. Just keep coming to me. Follow my voice. Explain what's going on around them, what they're going to be feeling, what they're going to be touching, what you want them to do. Right? And if they need that help, then you can provide that help. But we want to let them, like the hearing impaired, sight impaired, things, all the patients. We want them to do as much as they can on their own. And then once they can't anymore, then we step in and provide that assistance. Bariatric patients, right? We talked about this already with the BMI, the care of these kind of patients. If they've got other disease processes going on, like diabetes and CHF and emphysema, some kind of cancer, and that's not why they're actually there for surgery at that point, right? This can kind of complicate things. There's some additional risks associated in terms of staff injury or patient injury, falls, things like that. Typically, we put SCDs or sequential compression devices on these patients because remember what I talked about with the vein, your blood in your veins, and how it gets back to your heart, how you pump it around. There's a little residual pressure from the arterial system, but most of it is you moving around and your muscles moving and squeezing. That kind of squeezes on those vessels and moves that blood along in the vein system, in the venous system. But when they're now laying flat, not moving, which could be for a good 2 to 3 hours, depending on the surgery we're doing for these patients and things like that, you're going to have a lot more tendency to pool because bariatric patients have a lot more vascularity. There's a lot more tissue to get nutrients and oxygen to. So there's a lot more blood in the system, a lot more chance for pooling. So that's why we give those SCDs, and they just kind of squeeze the legs intermittently so that we keep that blood flow going and don't cause any clots to form and things like that, potential thrombus and emboli. But there's special equipment for the bariatric patient. Right? We have bariatric gurneys, bariatric wheelchairs, bariatric ORs, and these are all rated to withstand a certain amount of weight. And like I think you can put like up to 1,000 pounds on some of the the bariatric OR tables, right? And those tables tend to be a little bit wider, right? You've seen the ones in the lab, very narrow. They tend to, and they have also different attachments and things you can put on the sides of the beds that if you need to widen the bed, you can. You would need like a larger blood pressure cuff to go around a bigger arm, right? And if you're putting a tourniquet on, whether it's the arm or the leg, you may need the biggest size, like a 40-inch or I think we have a 55-inch tourniquet as well. So we do have things, special equipment and things like that, and supplies for the bariatric patient. If you're doing some kind of laparoscopic procedure on the bariatric patients, we have bariatric laparoscopic instruments. They're longer. Right? They're still as skinny as the ones you saw on the laparoscopic tray earlier in the week, but now they're just longer because you have more tissue to get through before you actually get into that cavity. So you need them longer. Police custody. I think there was a question about this maybe yesterday or Monday in lab about how you would deal with patients who were prisoners. It does happen. I've worked on quite a few. we have to kind of cooperate with law enforcement, right? But we still have to take care of the patient, right? Whether that patient's, a prisoner or not, to us, they're still a patient. Right? We're not going to treat them any different than any other patient that we have. I mean, even if they, killed 50 kids or raped a 2-year-old, I'm not condoning those actions. But all I'm saying is they're still a patient. A patient is a patient. Well, typically these patients will be accompanied by 1 to 2 officers. Most of the time, you're going to see 2. One will stay with them for the entire length of their stay in the operating room. They will actually come into the OR with the patient. They will have on, they typically leave their uniform on, and they put on a coverall. We call it a bunny suit because it's white, and it has a big zip. It's like a big onesie. But they get dressed in that, and they'll put a hat on, mask, all that, but they'll wear their sidearm on the outside of that bunny suit so that they have access to it. Patients are going to have restraints on. Some of them will have both hand and leg. Some just leg. Depends on the severity of that particular person's offense and their flight risk kind of thing. And then when you introduce yourself, you'll introduce yourself to the patient and to the officer. It's almost like you're treating the officer as their family member. And then when you explain this procedure, you're going to explain it to both. That second officer is going to be out by the front desk or waiting area. So that way you've got 2 places kind of covered and staged. These patients, when they come to the operating room to have surgery, they are not booked under their real name. They're given an alphanumeric code, and that's how we refer to that patient. We do not call them by name. They don't even tell the patient on what day they're going to be having surgery, because they do not want that patient contacting anyone on the outside as to where they're going to be and what time they're going to be there, so that an escape can be staged. The officers are the ones who are responsible for protecting that patient from doing any kind of self-harm or harm to any one of us in the hospital. So that's why that officer is there, is to protect that patient from themselves and protect us from that patient in case something were to happen. Positioning. We talked about this week. We talked about the different positions and why we even do positioning of these patients, right? It gives us that best access to whatever piece of anatomy we're going to be working on. So if we're working on a kidney, we need to put that patient on their side because that gives us the best access, right? We're trying to reduce any kind of physiological effects. We're not trying to have the patient stretched and tweaked into some weird kind of way or something like that just so we can get access somewhere. We want to put them in a comfortable position and still then have access to what we need to. It has to be able to permit the ability to monitor that patient anesthesia-wise, right, with the EKG pads and the pulse oximeter and the blood pressure cuff. Right? What happens if we are doing surgery on this arm? We need to put the blood pressure cuff on the other arm, right? Or if we're going to be laying that patient in lateral position, we don't want the blood pressure cuff on the down arm that they're going to be laying on, because it may kind of change what the monitor says. So that blood pressure cuff would be on the arm that is facing up for lateral. But it could be we are doing surgery on this arm and the patient has had a mastectomy with lymph node dissection on their right side, which means we cannot take blood pressures from that arm. Now we have to put the blood pressure cuff on the leg to get blood pressures because we can't put it here. We're working on this one. And they already said no to this one. So now we need to move it down to the leg. Now positioning, if they're lateral, it's got to be on that top leg. And give us that kind of unobstructed access for the surgeon. Right? There's not some piece of equipment that they have to get around first, or there's not, bone or other structures and things in the way. We got that direct access. But the surgeon is the one who is ultimately responsible for the positioning of that patient. And it's the anesthesiologist who calls out when we can move the patient. So knowing your anatomy and physiology is very, very important when deciding what position we're going to put this patient in. Because you got to know where those structures are to be able to, hey, we're going to be, taking out somebody's spleen today. And then someone tells you, so then we're going to put them in prone position. You know that they don't know their anatomy very well, because the spleen lives in the upper left quadrant of your abdomen. So if you put them prone, you're going to have to go through ribs to get to it. If you leave them supine, we can just go through a midline incision and reach over there and grab it. There's a lot of planning that goes into it for positioning these patients, because you got to think about all the equipment that you're going to need. Right? For putting a patient in lithotomy, you need stirrups and some egg crate padding. Right? Not for equipment that you need. But if you're putting the patient in lateral, now it's, okay, so are we going to use the gel rolls? Are we going to use the beanbag? Are we going to use the pegboard? I need a pillow for in between the legs. I need the axillary roll. I need the overhead arm board. I need the attachments to the OR table so I can actually hook the overhead arm board onto it. I need the safety strap. I need, some things to wrap that arm that goes on the overhead arm board to wrap around it that'll keep it up there. So, during the case, we're bumping and moving things around, that arm doesn't slide off of that, hang down. And then teamwork, right? We're going to need a minimum of 4 people to position this patient, because the patient is asleep and they're unconscious. So a lot of things that kind of go into this, and a lot of it's going to be mental. You thinking about what you need, what's coming, where, what are we working on? How do we need to put that patient in, or what position do we need to put that patient in to work on that item? What stuff do we need to put that patient in that position? Some of our duties is knowing these common positions and the surgeries that go with them. Right? You should know ahead of time what position your patient's going to be in based on what surgery they're having done. Right? We're proactively preventing any kind of injuries and accidents, right, by thinking about these things ahead of time. Right? And then if there's a place you put a patient in the stirrups, and you typically just pad the heel and the bottom of the foot, but you notice that this particular patient, the side of their knee, if everyone feels the side of the lateral side of your right knee, and you can feel there's like some of your tibia, there's some bone that can kind of be sticking out there. Well, that happens to be resting right up against the hard plastic of the stirrup. You can think to yourself, that's kind of a bony prominence. Let me just take a piece of this pad and stick it right there and just cover that. Or you could ask somebody like, hey, do you think maybe we should put a piece of pad right here? This feels like it's kind of rubbing up against this. Yeah, sure. Or should we put another safety strap across that patient's chest because they look a little unstable to me? But always you remain alert. You're always watching to see if things are falling off the table, if a patient's foot has fallen off the table or something like that. Always on the lookout for things that could potentially cause harm and injure the patient. And then, of course, lastly, communication. Most of the time when patients are getting positioned, we're scrubbed in at our table, and it's our job to watch and observe and make sure that there's not an area that's getting pinched, or that both legs were raised and put into the stirrups at the same time, and things like that, because the patient's asleep and they can't tell us if something is hurting or is uncomfortable or anything like that. And so you got to look at the patient, and if it looks like they're a little kind of tilted one side, or it looks like it might be uncomfortable, and you're looking at it, you're like, ugh, like, like laying like that would hurt my back. If it's going to hurt you, it might hurt them. So do something to take that away. Do what you would do for you. Right? If you're laying flat on your back and you're like, I can't do that, it hurts my back, I got to put a pillow under my knees. And you hear a patient going, oh, my back's really hurting, when they first move over, you go, oh, here, let me throw a pillow under your knees. Take some of that off. Or if you're seeing that the patient is now asleep or whatever, but you can kind of see a real arching of the back as they're laying there supine, you could just throw a pillow under there anyway. Help take some of that stress off. We're going to go ahead and pause and stop here on number 31, because a lot of the stuff you guys have seen already in lab, so it'll be quick to go to bust through, and then we'll start on 19 on Friday. This evening, keep a lookout on your school emails. The chapter 15 video will be coming to you, and I'll also send out a text to let you guys know that it has been sent. So you don't have to keep like going back to your computer every 15 minutes. Did he send it? Did he send it? Did he send it? Let me do this. Does anyone have any? Let me check the chat here, make sure. Does anybody have any questions, concerns? Make sure I've gotten everybody here. Yep. Okay. So if you don't have any questions or comments, concerns, or anything like that, then enjoy the rest of your day. And Group B and C, I will see you tomorrow in lab.